Yep, I just need to start.
Let me know, Sarah, when your
We are ready.
technology is
We're
ready.
ready to go whenever you are.
So you're ready on your YouTube channel and everything?
Yep, we're live on YouTube now, so the meeting hasn't officially started, but we are already streaming for
Okay.
those who are on our YouTube channel. So whenever you're ready
So
to
we'll
call
give it
it.
another minute.
Yep.
Just another minute, so then we can start. All right, it's 9 a.m. So I'll call the meeting to order and would request Leslie for the roll call. Leslie?
Good morning, everybody. Thank you, Chair. I will start with our voting commissioners. Dr. Khan,
Present?
Dr. Barron,
Present.
Teresa Bohannon,
Here.
Babette Bond. Babette with us?
It looks like she has not joined, but I did not get an indication that she wouldn't be joining us today, so.
Okay, I'll skip her right now. Jessica Flood,
Here.
Flo Khan,
Here.
Dr. Packham,
He may be on mute. He's here.
yeah, I see him.
He is on mute.
Yarleni Roa Dugan,
Here.
Sean Shaner,
Present.
Dr. Slonim,
Here.
Mason Van Halling, is Mason here?
Mason is not here yet.
Okay.
But again, I have not heard that he wouldn't be attending, so perhaps both Commissioner Bond and Commissioner Van Halling will be late.
Okay. Moving on to our advisory commission members, we know that Commissioner Heather Korbulik is absent today and excused. And Barbara Richardson.
Morning, everybody.
Good morning. And Richard Whitley.
Here.
All right, thank you.
Hi,
Mr.
Leslie.
Chairman,
John Packham, I'm here.
right. We saw you. Mr. Chairman, that concludes our roll call, and we do have a quorum.
Okay, great. Thank you very much. Appreciate that. Moving along on our agenda, next item is public comment. Sarah, you want to take on, see who's on for public comment, north
Sure.
and then south?
Yep. Okay. So anyone, thank you for joining us. Any one of our attendees who joining us via Zoom, if you can go ahead and indicate that you'd like to speak by raising your hand now, selecting that option. If you're joining us on the phone, you want to press *9 to indicate that you'd like to speak. Okay, Chair, we have one person. Attendees, I'm going to move them into our meeting, and it looks like it's Honorable Shelley Berkeley.
All right. Let us know when you're connected.
Okay, she is in and she should be able to be speaking now.
Dr. Khan, can you hear me?
Yes, Shelley, thanks. We can certainly hear you.
All right. That has never been an issue for me, actually. I want to thank everybody for giving me the opportunity to make public comment. My comments are going to be restricted to GME and ensuring that the GME fund continue, even though I know that we are facing daunting financial prospects in the next legislative session. As you all know, we have one of the lowest numbers of practicing physicians in the state of Nevada. Specialties, yes, primary care physicians in extreme shortage. We've been very lucky between UNR, UNLV, and Touro University to be educating the next generation of healthcare providers for the state. But as you also know, our residencies or our GME funding or GMEs for our graduating medical students is exceedingly low in the state of Nevada. I believe we're 47th or 48th. Ordinarily, as you all know, GME funding comes from Medicare. If we're going to wait for the Congress to allocate additional GME funding, I'm afraid we're not going to be able to provide any more for the state of Nevada. Governor Sandoval, when he was governor, quite wisely recognized that we had a serious challenge in attracting doctors and keeping doctors here in the state of Nevada, creating our own GME funding to be able to create graduate medical education will, without a question, keep doctors here or keep future doctors that are graduating from our state schools and Touro University. We now graduate 180 future doctors every year. If we don't provide adequate GME here in the state of Nevada, and the statistic is that 70% of doctors end up practicing where they do their GME. If we don't provide that funding in order to create graduate medical education programs throughout the state, I'm afraid a vast majority of our graduates end up going elsewhere in order to satisfy their 3-year residency requirement. Chances are, unless they have a tie to the state of Nevada, they are not coming back. So it makes tremendous sense, even during a time of restricted funding, to fight for graduate medical education up at the legislature. I know that when Steve Sisolak became governor, he supported the GME program, and I would urge everybody here to support this effort as well, understanding fully that there will be serious financial restrictions, but I think we need to start thinking past the pandemic and how we're going to be able to provide adequate number of doctors for the population in our state. And of course, during the pandemic, I think we all see the importance of our healthcare providers to all of our well-being. And I'll be glad, if it's appropriate, Mr. Chairman, to answer any questions. And if not, thank you very much for your kind attention.
Thank you very much, Shelley. We have a GME presentation by Dr. Packham later in the program. So if you have time, you may want to listen in at least to what he has to say, because he's also just as passionate about GME. I certainly am very passionate about it. And I think most of the commissioners are keen to see that happen. So we appreciate your presentation. So please, if you have time, chime in. Otherwise, later you can have access to his presentation.
Thank you. And I spoke with Dr. Packham, and I will definitely listen in on his presentation. Thank you all so much.
Thank you, Shelley. Appreciate it. Anybody else, Sarah, for public comment?
We do not have anyone else in public comment.
Okay, so moving along for the next item 3 on the agenda. For possible action, approval of November 30th minutes, I need a motion and a second.
This is Tony. I move to approve the minutes.
Is there a second?
Aaron, second.
Thank you. Any opposed? If not, the motion carries. Minutes approved as presented. The next item is item number 4, opening remarks by the chairman. I don't have a whole lot to say. All I need to say for sure is I'm really genuinely, honestly, deeply thankful for the commissioners, for their commitment, their engagement. We have accomplished a lot. There's a lot more to be accomplished going forward. And I think if we stay focused, I'll try as my best as I can with your cooperation to keep these meetings limited in time, so that we don't burn out with the long meetings. So that's my opening comment. The next item on the agenda is number 5, presentation on uncompensated care costs for the nation's uninsured and the sources of funding to defray these costs. We have Teresa Coughlin here, or if she couldn't make it. Senior Fellow, Urbane Institute, Teresa. We also have Michael Kapman, Senior Associate with the Urban Institute. Do we have anybody from the Urban Institute for
Yes,
this presentation?
Mr. Chair, they're both on, and I think if we can just give Leslie a moment to share her
Yeah, I'm
screen.
going to go
for the
ahead.
slide deck.
And if they could unmute themselves, please.
Yep.
Hi, this is Michael.
Good morning, Michael. Good morning, Ms. Coughlin. It's nice to see you. Thank you so much for joining.
Good morning.
you.
I would appreciate if we honor the time restraints we have, because I'm sure the commissioners will have questions on your presentation.
Can everybody see this?
Yes, we're
Okay.
good.
Good morning. My name is Terry Coughlin, and I work at the Urban Institute, which is a research organization in Washington, D.C. And at the Institute, we study a range of domestic policy issues, from housing to income security to health policy. And my co-presenter, Michael Cartman, today, we are both in the Health Policy Center at the Institute. We're happy to be here this morning to present some work we're doing on uncompensated care costs for the uninsured. Next slide, Leslie. Before I get going, I wanted to acknowledge our co-authors, Haley Samuel Jacobus and Rachel Garfield, and also our funder, which is the Kaiser Family Foundation. And I also wanted to note that this work we're presenting this morning is a work in progress. So some of the estimates that we present today may differ slightly from what our final results are, which we hope to have available in a few weeks. Next slide. Leslie, next slide. Okay, thanks. So as we all know, the ACA significantly reduced the number of uninsured in the United States. An estimated 20 million people gained coverage because of Obamacare. But even with this significant coverage expansion, many millions remain uninsured, as you all well know. In 2019, nearly 29 million people were estimated to lack health insurance nationally. And while the uninsured use less healthcare compared to their insured counterparts, when they do use services, they often can't afford them because healthcare is costly, and many uninsured are also low income. So often the care provided to the uninsured goes uncompensated. And sometimes providers absorb the cost of care associated with treating uninsured patients. But at the same time, federal government, states, and local governments have long provided funds to help providers offset these costs. And examples of these include prominently the Medicaid disproportionate share payments, or DISH payments. Sometimes the funding that is provided to offset these costs is directly linked to the treatment of the uninsured patient, but funds are also paid in lump sum payments to providers, like in Medicaid DISH payments are issued that way. Next slide. So building on previous work that we've done at the Institute, we are in the process of doing a 2-part study. And in the first part, we estimate total national uncompensated care costs for the uninsured before and after the ACA. And we estimate uncompensated care costs for the non-elderly population, ages 0 to 64, who were uninsured for part or all of the year. And we exclude the elderly because they are largely covered by Medicare. For this part of the analysis, we used data from the Medical Expenditure Panel Survey, which is, or the MEPS. It's a nationally representative survey of the civilian non-institutionalized population. And critical to our study is the MEPS provides lots of data, but it provides monthly insurance coverage for each individual, as well as his or her healthcare spending in that month. Our analysis does not include uncompensated care for the long-term care population, because these groups are excluded from the MEPS survey sample frame. Then in the second part of the analysis, we used government program data to look at public funds that are available to help providers defray the costs of care provided for medical services to the uninsured. And these services include hospital care, physician care, other professional services, and prescription drugs. Long-term care services were excluded here as well. We only look at public funds, funding. We don't include private funding that is used to support services provided to the uninsured, such as philanthropic organizations or community-based groups. So with that, I'm going to turn it over to my co-presenter, who's going to present findings from the MEPS, which is the first part of our analysis. So Michael, you're up.
Great. Thank you, Terry. So if we could move to the next slide, please. Great. Thanks. So as Terry mentioned, we used the Medical Expenditure Panel Survey, or the MEPS, to estimate uncompensated care costs for the uninsured. And the MEPS is really the gold standard federal survey on healthcare expenditures, and it's conducted by the Agency for Healthcare Research and Quality. So respondents are interviewed 5 times over a period of 2.5 years, and they provide information about every household doctor visit, hospital visit, drug fill, and other medical events for the survey. And their reported costs for these services are validated by a follow-up survey with their healthcare providers and pharmacies. And so we define in our study, we define uncompensated care costs as costs for services that were received in a month where the patient was uninsured and were not paid for out of pocket or by a comprehensive health insurance plan. And so this definition has 2 components. The first is what we refer to as indirect sources of payment that are linked to the patient. So these sources can include VA spending, Indian Health Service, state and local government, workers' compensation, and other private sources. And the second component is something that we refer to as implicitly subsidized care, which we define as the difference between the expected payments that providers would receive if an uninsured patient was privately insured, the difference between that amount and the actual payment that the provider receives. So these are cases where the providers are offering an implicit subsidy for providing care to a patient. And this subsidy, these services can be accounted for by medical debt. They could reflect charity care. They might be offset by disproportionate share hospital payments. And they don't necessarily show up clearly in the data in that way. And so we're looking at changes before and after full implementation of the Affordable Care Act's major coverage provisions in 2014. So our pre-ACA period that we're looking at is 2011 to 2013, and our post period is 2015 to 17. And we pool these data across years because the larger sample size produces a lower margin of error for our estimates of uncompensated care costs. Next slide. This chart shows overall average annual spending by the uninsured was about $89 billion in the pre-ACA period of 2011 to 2013. Most of that, $62.8 billion, was uncompensated care. The uninsured also had $21.6 billion in out-of-pocket spending. And then this remaining small sliver of $4.6 billion was other public spending, which is Medicaid payments for people who didn't report being covered by Medicaid during the year, which could reflect presumptive eligibility. You'll see in this chart that both total spending and uncompensated care costs fall by about 1/3 between the pre and post ACA periods. So uncompensated care costs fall from an annual average of $62.8 billion to $42.4 billion between 2011 to 13 and 2015 to 17. And this decline was statistically significant. Something that's not shown in this chart is that we also found that Medicaid expansion states had lower uncompensated care costs in both periods. And those states also experienced a larger relative decline in uncompensated care costs among non-elderly people with incomes below the federal poverty level compared with that same group in non-expansion states. And that's part of an ongoing analysis that we're doing. And so if you look at the bar on the right, in the post-ACA period, you'll see that about $27 billion in uncompensated care costs were from these indirect sources of payment, and about $15 billion was from implicitly subsidized care. And the uninsured also paid about $13 billion out of pocket annually in this post-ACA period. Next slide. Okay, so this table shows the distribution of uncompensated care costs by the type of service or the place where people receive services. And you'll see in both the pre and post ACA periods, about 60% of uncompensated care costs were incurred in hospital settings, including inpatient stays, emergency department visits, and outpatient visits. And then about 30% of these costs were in community settings, including office-based visits to providers, home health, dental, and medical equipment. And 9 to 10% were for prescription drugs. And so in both hospital and community settings, annual average uncompensated care costs declined by approximately 1/3 between the pre and post ACA periods. So hospital uncompensated care costs fell from $37 billion to $25 billion, and uncompensated care costs in community settings fell from about $20 billion to $13 billion. And the asterisks next to the numbers just indicate that the change was statistically significant. Next slide. And so the change in uncompensated care costs under the ACA tracks with the decline in the uninsurance rate. The annual average number of people who are uninsured at any point during the year fell from over 70 million in the pre-ACA period to about 53 million. And the number who are uninsured all year fell from 41 million to about 24 million. We didn't see a change in the number who are uninsured for just part of the year, which was a pattern that's consistent with other data sources, including the Urban Institute's Health Reform Monitoring Survey, which we've been fielding since 2013. And so this might reflect continued churning between coverage types and uninsurance as people see changes in their employment and their incomes, while at the same time we're seeing fewer people are persistently uninsured all year. And it could also be that some people who would have been uninsured for part of the year before the ACA are now insured year-round, or that there are some people who would have been insured all year but are now insured for part of the year. Next slide. Okay, and so this slide just shows the breakdown of annual average per capita spending in the post-ACA period of 2015 to 17 by health insurance coverage status. It includes all expenditures that were made when people were uninsured or insured during the year. And so one notable finding is that you can see that the people who are uninsured use a lot less care than people with coverage. So people who are uninsured for a full year spent an average of $2,000 per capita, compared with almost $5,600 for people who are covered by insurance all year. And then the people who are uninsured for part of the year were in the middle, spending about $4,000 per capita. And most of that spending occurred while they had insurance. And then the second key finding here is that among the people who were uninsured all year, you can see that almost 3/4 of their per capita spending was uncompensated care. So out of the $2,000 in per capita spending, nearly $1,500 in costs were for implicitly subsidized care or from indirect sources of payment. And the full year uninsured also spent about $390 out of pocket per capita, which is not very different from the per capita out of pocket spending of people who are insured part year or year round. And so the large gap in overall spending that you see here is a result of insurance coverage. And so with that, I'm going to turn it back to Terry, who's going to talk about our analysis of public sources of spending for uncompensated care.
Thank you. So this is the second part of the analysis that we're doing, and that we looked at government data to estimate the federal, state, and local funding available to help providers defray uncompensated care costs. And we looked at data for 2017. And to the extent possible, we tried to match the funding sources for services to those services that we examined in the MEPS data that Michael just presented. And as shown in the next slide, we estimate that there's a total of public funds available to help cover the uncompensated care for the uninsured is $32.4 billion. And federal government funding accounts for the bulk of it, nearly 60%, with state and local governments picking up the rest. Next slide. So this shows the different funding sources we considered and the share we estimate that each of the sources contributes to fund uncompensated care costs for the uninsured. So we included Medicaid DSH payments, Medicaid uncompensated care pool payments, state and local indigent programs, the VA, state and local public assistance, and then in the category of other programs included Ryan White, HIV/AIDS, the Indian Health Service, and community health centers. So as you can see, between DSH and the uncompensated care payments, Medicaid is the single largest funder of uncompensated care costs, with state and local indigent programs and the VA coming up very close behind. And while we included the major funding programs, we acknowledge that there may be funding from other public programs that we're not capturing. And so to the extent that that's true, we're underestimating the availability of public funding. So if you take these estimates of what funding is available, public funding available to cover the uninsured, and compare that to the estimate based on the MEPS data that Michael presented for the 2015 to 2017 period, and that was $42.4 billion. These findings suggest that a sizable share of uncompensated care costs for the uninsured are mitigated by the public funding that is available, about 75%. But importantly, this is at a system level. It is not at the individual provider level. So, and past work has shown that public funding for uncompensated care is far from perfect. So there are certainly providers that have sizable uncompensated care costs that receive little or no compensation for that care. Next slide, please. So in conclusion, our analysis shows that the ACA brought about a significant reduction in the nation's uncompensated care costs for the uninsured, lowering it by nearly a third. We also find that where uncompensated care occurs has not changed much before and after the ACA. Hospitals still account for the majority, nearly 60% of uncompensated care costs. And this makes sense. I mean, hospital care is costly. And though the uninsured have much lower healthcare spending than their insured counterparts, most of their healthcare spending is uncompensated post-ACA. But at the same time, we estimate that the uninsured paid nearly $13 billion in out-of-pocket costs in the post-ACA periods. And on a per capita level, their out-of-pocket spending is comparable to that of a fully insured individual. Finally, we show that at the system level, national level, government funding covers the bulk of uncompensated care costs for the elderly. But again, this is at the system level, not at the individual provider level, which is where it really counts. Next slide, please. So in closing, I wish I could say that since 2017, uncompensated care costs for the uninsured have continued to climb, but sadly, that is likely not the case. Since 2017, the level of uninsurance has increased. Between 2017 and 2019, the number of uninsured grew by an estimated 1.5 million people nationally. And in 2020, the number of uninsured has likely continued to climb, particularly given the pandemic. Also in 2020, the Trump administration's public charge rule was implemented, and past studies and experience suggests that the rule will likely have a chilling effect on eligible immigrants' enrollment into public coverage programs through disenrollment or deterring enrollment, new enrollment. And then in addition, the federal funding for enrollment assistance and outreach for the ACA has been cut back over the past few years, which also can have a dampening effect on enrollment into public programs. And then overlaying the decline in insurance coverage, we also all are very acutely aware of the economic impact that the pandemic has had, which raises important implications for future funding, public funding of uncompensated care costs for the uninsured. And that is the end of our presentation. We'd be happy to answer any questions, if we can, that you might have. Thank you.
Thank you very much for that presentation, very informative. So we'll proceed, Sarah, in the format so that every commissioner has an opportunity to ask the questions. So Sarah, could you proceed recognizing each commissioner, please?
Yes, absolutely. Let's go with Commissioner Bohannon first.
Thank you. Thank you for the presentation. I think that was very, very informative. Looking at the funding to compensate some of the uninsured costs, and with it looking like the bulk of it being from Medicaid, I don't think that you all would be able to answer this, but I'm curious if there's any way to determine if this is sort of, and kind of overlaying that with a lot of the uncompensated care being in the hospital setting, I'm wondering how much of this healthcare is tertiary and not primary, and that ending up actually costing more to the Medicaid programs because people who don't have insurance aren't seeking the primary care that they would need, and then they're ending up in an emergency department with an unmitigated type of event that could have been resolved in a physician's office, say like some sort of chronic disease that isn't being managed. Is there any way, or is that anything that you all have looked at, or is there any research to kind of support a theory like that?
Well, I can say that, I mean, based on this analysis, we see that the bulk of the uncompensated care takes place in the hospital setting. I think it's nearly 60%. So, but I don't know, I mean, to answer your question directly, is it if they had received care in a primary care setting, we could potentially lower their costs. We don't have that information. Michael, are you aware of any studies that have tracked that? I mean, that's kind of the motivation for giving people insurance, is that they do seek care because they have insurance and they don't have to pay, that they get coverage earlier rather than later. But Michael, do you have any further thoughts on that?
Yeah, I'm not sure. I mean, it's not something that we've looked at in detail. I think that it's possible to dive deeper into data and kind of look at a more granular level of to see the types of services that are being paid for with uncompensated care, but it's not something that we've done yet.
Right. So I guess you could look at their diagnosis and what the treatments were to see.
Right.
Thank you. Next commissioner in line, Sarah.
Commissioner Roa Dugan.
Thank you so much for the presentation. I do not have any questions at this time.
Thank you. Next commissioner in line.
Commissioner Flood.
Yeah, I was wondering, thank you for the presentation. Excellent. Do you see any trends in differences between the rural population and the urban population in uninsured costs? Have you that?
So far, we've only looked at the trends by state Medicaid expansion status, and breaking it out by rural versus urban hasn't been part of the scope of our analysis.
But you could do that.
Yeah, I would be interested in that. I mean, I don't know if there would ever be a follow-up on that, but I know that there's a lot of conversation in that rural versus urban, and that's definitely pertinent to Nevada.
Right. Mm-hmm.
All right. Thank you for that. Next question.
Sure. Commissioner Flo Khan.
Hi, I'm sorry, I'm not on video, but I would just follow on with the Commissioner Bohannon's comments, because I do think that information on better understanding how the uninsured is using the care, particularly those new to the system, would be really helpful. So if there was a way to provide any additional information in that area, I think that would help guide us. Thank you.
Thank you. So before we leave the subject, I just want to make a comment. You mentioned 60% of care is in the hospitals for uncompensated care, rather. And that makes sense because the uncompensated care people, uninsured, do not seek routine healthcare visits to their primary care and other services. And they get into the hospital when they're sicker. So the sicker they are, the more the cost of the hospitals. And they are the ones who are the worst hit, certainly in Nevada, with a significant uncompensated care. At a later point, at some point, we may want to have data from the Hospital Association on that. So having said that, we can move on to the next question.
Okay, Commissioner Shaner.
No questions at this time. Thank you.
Okay. Commissioner Bond.
Thank you. I have a technical issue that made me miss the very beginning of your slide. So you may have already addressed this, and I'm sorry. I'm trying to understand exactly how you're defining uncompensated. Is it based on what? What's the price? How is that determined?
Yeah, so in the survey analysis, these are costs for services that were incurred when a patient was uninsured during the month and did not pay the services were not paid out of pocket, and they were not paid by a comprehensive health insurance plan, linked to the patient.
So is there some sort of number that you're using to figure out the actual cost of the care, or is it just the price of the care?
Yeah, so the federal survey that we use is it looks at both charges and payments, and what we're using are payments. And so I mentioned that the two components of uncompensated care were these indirect sources of payments, which are things like VA, Indian Health Service, state and local government funding. And then a second component was implicitly subsidized care, which is sort of the difference between what the provider would have expected to receive in payments if the patient was privately insured and what they actually received because the patient was uninsured. And so together those two add up to uncompensated care costs. But yeah, it's not, it's what we're looking at in the data are actual spending for the most part.
Actual spending, but not actual cost. So I think that's super helpful. I really appreciate it. I think it's hard to get to what the cost of care really was. And I think these studies always have to be careful about terms. So this is I'm glad Urban presented this. I do have just one sort of comment I'd like to add to the dialogue in general, but not about your study, which I appreciate. I think a lot of this subsidized care is really coming from the private insurance. And I think there's this wonderful work being done by organizations to figure out the percent of burden picked up by private payers, because they just pay so much more than Medicaid or Medicare does for the care. And it's allowed, it's a burden on our private health insurance negotiations constantly, and I think others can talk about that. But specifically, Sarah, it might be helpful to distribute to this group the RAND study. There's been 2 RAND studies that have talked about the difference between what we pay and what the public sector pays for care. And I think that's why we should understand how much care actually costs more. And it kind of gets back to our whole transparency thing. But I think it is important to know when we say uncompensated, which part, the actual cost of the care or the price of the care. Thanks.
Thank you for that good question there. So next commissioner in line.
So we have Commissioner Slono.
Thank you, and thank you very much for your presentation today. A couple of comments and questions. As unfortunate part, I've actually used MEPS before as an investigator, so have probably some more detailed questions than others might have. You use the insurance or the patient level panels for this analysis?
Yeah, so we are using the household component, which is patient level data. Yeah.
Okay, very good, thank you. And so that represents, if I understand MEPS correctly, a sample design that accounts for about 30,000 households nationally a year.
That's the sample size.
Right,
yeah.
And then generalizes beyond that using statistical techniques to get to estimates of expenditures and costs.
Correct.
Okay. Again, could you comment perhaps, I think it's important for the commission, limitations to the study that you guys would proffer?
Well, so as Terry mentioned, I think, one major limitation is that, the survey is focused on the non-institutionalized population. So we are, we're missing, people in long-term care settings, we're just looking at this non-institutionalized household population. We're also, because the MEPS tends to capture less spending than the national health expenditure accounts, we make adjustments to the data so that the uncompensated care cost estimates and spending estimates are more reflective of national health spending. I think those are two of the key limitations of the study. And then I guess I would also just mention that, things like health insurance coverage and, healthcare use and spending can be reported with error in surveys, and, the MEPs, the people who run the survey work to ensure that, do their best to ensure that the data are as accurate as possible.
Right, certainly, particularly with the household component, there's recall bias because you're investigating individuals at the household level that you want to make sure you're hearing from. In addition, it seems to me that while your analysis is certainly very helpful pre and post ACA, I think it's pretty safe to say that the findings don't lead directly to intervention. Right? Very helpful as a backdrop, but not a place where I would want to say, hey, line this up with interventions at a policy level. And if I did, I have to realize that I would be expanding beyond perhaps the extrapolation of the study. Is that accurate?
So, I think that when we're looking at the trend in uncompensated care costs, we're picking up changes that result from increased health insurance coverage, and as well as changes that could result from an improving economy, between 2011 and 2017. And that's why, we're doing this other study focused on Medicaid expansion that seeks to get a better understanding of the causal effect of that particular part of the ACA.
Got it. And the data, when you say 2017, this was a question I actually had. The data are collected in 17 or collected in 16 and reported in 17?
So the data are collected over a 2.5-year period for 2 calendar years. And so at the time,
data reported in 17 go back to 15, perhaps?
They're reporting basically on a they're surveyed 5 times, and they're reporting on a reference period of like the previous several months each time they're interviewed.
Got it. On the moving from the macroeconomic to the microeconomic, and this is particularly important given that in the definition of uncompensated care, Medicaid, right, and the expenditures are not included, if I understood your definitions appropriately. Uncompensated care related to Medicaid is not included in your definition.
Yeah.
Are you talking about the shortfall?
Mm-hmm.
Right. No, we're not including that.
Got it. And so as I'm moving from the macroeconomic to the microeconomic, do we have sufficient sample size? For example, if we wanted to understand better the care attributes within Nevada, given that there are 30,000 people in the sample nationally, I don't know how many would be. Are you able to get to state level? No, you can't. You can't make that extrapolation point or generalize to state level examples. If I'm accurate here.
Michael, if you're maybe if you're a populous state, you could. Michael, maybe like New York or Texas or California, but unfortunately not for Nevada. Michael, you agree with that?
Yeah, I think that's probably right. I think that, you're starting with a small sample size, and then you're looking at an even smaller subset that are uninsured.
Yeah.
You could do, as we suggested earlier, that you could do regional-based analysis or like states like Nevada or something, and group them that way as a possibility.
Yeah. That was my understanding from you having used the data as well. Getting from the macro to the micro is certainly challenging.
Yes.
And then finally, I think that your point so well articulated and has face validity, as Dr. Khan mentioned as well. The fact that 60% of the care of uncompensated care is in hospitals has face validity, and we know the reasons for that, particularly in a state that is underrepresented in terms of primary care, has workforce shortages, we all are subject to regulations on the hospital side of when somebody shows up to the emergency department, we are obligated to take care of them because obviously we want to make sure they get the care, and they may not have, unfortunately, any other source of care besides the emergency department, which drives up the uncompensated care concentration in the hospital setting. So thank you for that. Certainly reflects well from a face validity perspective on what we see on the ground. And it's nice to see that come through the data. That's all I have, Chair Khan.
Thank you, appreciate it. Again, staying on the same subject, if I may ask, uncompensated care, certainly in the hospitals, we're talking about 60%. Have you looked at the uncompensated care to the physicians who are also obligated to take care of the uncompensated patient in the hospital setting coming through the emergency room? Does that include the uncompensated care for the physicians also, or just the hospitals?
It includes both physician and facility charges.
Okay, thank you.
Payments, yes.
Thank you. All right, next commissioner in line.
Commissioner Peckham.
I didn't have any additional questions. I appreciate the presentation. I actually was surprised that the uncompensated care in hospitals wasn't even higher than 60%. Good presentation, though. Thank you.
Thank you. Our next commissioner in line.
Commissioner Barron.
Thanks for the presentation. I had two questions. One is, I was interested in the bar graph that showed that there was actually less out-of-pocket payment if you were completely uninsured for the year versus if you were completely insured. And is the presumption that people that are fully insured for the entire year are spending more healthcare dollars and therefore have more out-of-pocket expense? And so it leads to the question of what's the denominator on that. So what we've been hearing is that the most expensive place to get your care is in the emergency room, and you would think that if you're completely uninsured, that you're going to be accessing care in the most expensive place possible. So my question is how in the world could people who have no insurance the entire year be spending less out-of-pocket money than people who are fully insured for the entire year if the denominator in terms of the amount of care that they're accessing is the same? Or is it just not the same amount of care, and that's why that number is different?
Yeah, so we didn't do a very close analysis of just utilization overall, but I think that, one thing that kind of comes out clearly in that chart is that the uninsured, people who are uninsured just use a lot less care in general. And so, I think that's part of the reason their out-of-pocket expense is lower than the people who are, insured all year. And I'm sorry, did that answer part of your question?
Well, that's I presume you're making that presumption, right? But I guess from what I'm hearing from you is that we really don't have the denominator of how much care or services were provided to the completely uninsured versus the insured, so that we don't really know what the denominator is in terms of dollars spent. And again, we're making a presumption.
Yeah, so I guess what you're saying is one thing that we could take a look at would be sort of the per unit or per event, payment, both overall and out of pocket, and to get a good comparison of the uninsured versus the insured.
Right.
Understand that.
So that might make that number more meaningful. My other question was, and I think maybe you're alluding to an ongoing study. It was there a comparison of uncompensated care between states that did not expand Medicaid versus those that did, and it would be interesting to see some data there. And it sounded like you were kind of in the process of making some comparisons.
Yes. So right, and this work is ongoing, and we are looking at the population that was targeted by the ACA's Medicaid expansion. So we're focused on non-disabled, non-elderly people with incomes below the federal poverty level. And we found so far, we've seen that Medicaid expansion states had lower uncompensated care costs to begin with compared to non-expansion states, but we're seeing Not really a difference in the absolute dollar decline, but a larger relative decline in uncompensated care costs for the expansion states compared to the non-expansion states. So it's something like, I don't have the exact numbers in front of me, but it's something like over a 50% decline in the expansion states versus something like somewhere between 20 and 30% for the non-expansion states.
So more to follow on that, it sounds like.
Yeah, that's right. We're currently working on that paper.
Thank you.
Thank you. For next commissioner in line.
Chair Khan, that concludes all of the initial round, but we do have Commissioner Bohannon who would like to speak again.
All right.
Thank you, and I'll make it very quick. So I'm interested in this idea of the subsidies and the supplemental costs and how they're with the uncompensated care or uncompensated costs. Who shoulders that responsibility? Does it fall to the consumer? Does it fall to the provider? Who is actually going and filling in that gap? So that's my first question. I don't know that anybody can really answer that because I'm sure it varies and it's probably a little bit of everyone. And then my second question is actually to Richard and to DHHS. Is this something that the state of Nevada could replicate? Do we have any sort of resources internally that we could, maybe not using maps, but doing something similar where we could look at, we could do something similar? Thank you.
This is Richard Whitley. Yes, I think we can. I think putting the question to our state biostatistician, I mean, we could basically give the Nevada narrative.
Thank you very much. So I think we can move along. This was very helpful, some good questions, and really appreciate that presentation by the Institute. I know you guys are busy doing a lot of stuff and putting together data, and this was on short notice. You were able to make yourselves available. So we really appreciate that. Thank you very much.
Thank you. Our
we
pleasure.
move on
Thank
to our
you.
next agenda item, a presentation on health workforce trends and policies in Nevada. Before I invite John, this has been a subject of great interest to most of us, if not all of us, about the workforce. It was one of our priorities. But we also added on this presentation the GME status to John. So we, at least I agreed that he may have another 5 minutes, John, compared to the previous presentation because of the addition of GME subject. So we'll proceed with that. John, you're on. I see your slide is on.
All right, I will go ahead and get started. I appreciate the Commission's interest and give me a little time to provide an overview of health workforce trends in Nevada. I'm going to focus particularly on provider shortages. I'm also going to conclude with a discussion of some of the policy measures and strategies we can take as a state. I'm kind of a half glass full person on policy. There is a lot out there that we know works to address shortages, whether we have the political will and dollars right now, given the budget crisis, is another matter. For 21 years, I've been at the School of Medicine and currently oversee the Office of Statewide Initiatives as Associate Dean, and I also co-direct the Nevada Health Workforce Research Center. The data I'm going to share with you today draws upon workforce data reports and analysis published by my office. Here's a couple of links to some of our work. The Nevada Instant Atlas, great repository of county level data, not just on health workforce, but health in general. Also have a brand new healthcare careers manual. I've got a bunch of hard copies. It's really hard to distribute hard copies of anything in the middle of a pandemic, but you can also find that manual online. And then after the first of the year, we'll be releasing the 10th edition of our Rural and Frontier Health Data Book. which will also be online. I'm going to cover 4 broad topics in my presentation, focusing on demand, that is economic demand from hospitals, clinics, nursing homes, and other employers of health professionals. I'm also going to provide a quick overview of some supply trends that I'm seeing and some that I'm concerned about. Third, I'm going to focus on provider shortages with explicit focus on primary care shortages, dental workforce shortages, and mental health shortages. I always try to caution, though, that we face regional and statewide shortages in all sorts of healthcare professions, lab techs in many hospital and clinic settings right now, billing and coding clerks in rural hospitals, epidemiologists and public health professionals, as we're painfully discovering right now, and so on. And again, I will conclude with a discussion of some of those policy strategies that I believe we can take to address these shortages. I want to mention real quickly, we talk about shortages, it's typically an imbalance between demand on one hand and the supply or availability of health professionals on the other. And just point out, this is kind of a pre-pandemic discussion that I think will continue to apply when we crawl out of the pandemic, but the 4 big sets of drivers, if you will, are demographic, insurance related, economic growth related, and population health related. For the past 2 decades, Nevada has been one of the fastest growing states in the country. In addition to rapid population growth, particularly in southern Nevada, our state's population is aging. We've taken a close look at some projections from the state demographer's office, and over the next decade, we are projected to increase our state's population by nearly 300,000 residents. And that segment of the population 65 and over, which will include yours truly, will increase by 120,000, or nearly 26%. And again, all things being equal, that will drive increased demand for health services and health workers. A second major driver, as alluded to in the previous presentation, has been some pretty phenomenal gains in public and private insurance coverage in the state resulting from the Affordable Care Act. And again, all things being equal, gains in coverage have accelerated demand for services and thus health workers. A third major factor is economic growth. Again, my comments will be a little bit pre-pandemic, but what we've seen up north anyway is what I call the Tesla effect. And in the case of the Tesla Gigafactory, their landing in northern Nevada has resulted in approximately 7,000 plus new jobs with decent pay and health insurance coverage that are, again, driving demand for health services and thus health workers. I'd conclude by saying population health is sometimes, but not always, a driver of healthcare. Certainly is with the pandemic. And I think what we're going to pay close attention to, at least from my office's point of view, is that the net impact of population health on workforce demand will probably take a year to shake out. We've seen a lot of postponed care, a lot of delayed care as a result of the pandemic. And I might add that we have population health issues that have not gone away. The opioid epidemic, mental health needs, just to point out two, are no indication that there are population health needs and demand out there that will return with the decline of the pandemic in 2021. I next want to turn to a couple of key trends in health workforce supply in the state, some good news, some bad news. I'll start with the good news. For the past decade, we've seen actually a pretty steady growth in the supply of licensed health professionals, including physicians, including registered nurses, and other health professionals. However, we've also seen what I refer to as the treading water effect in per capita growth of licensees. That is to say, when we adjust for that growth in licensees for population growth, some of those per capita gains have been pretty modest. Good example is the licensed physician workforce. Over the past decade, we've added about 2,000 licensed physicians in the state, an increase of 38%. Yet when we adjust for population growth, that per capita growth in the physician workforce has been a relatively modest 18%. We've actually had some professions when we adjust for per capita, such as pharmacists in the state, the growth has been flat, even though, again, we've grown in the overall number of pharmacists statewide. A third trend I want to point out is supply side related, that is we have an aging workforce serving an aging population. A good example are, I'll take medicine. The average age of a physician in Nevada is 55 years and has been increasing for most medical specialties. And nearly 30% of the licensed physician workforce is over the age of 65. I turned 60 this summer. Don't think it's all downhill, but I would point out, though, that the physician workforce, as are other sectors of the workforce, are growing older. And I have a concern that with the pandemic's end, those approaching retirement will be exiting the workforce at a little faster clip than is normal. Final set of workforce trends that are unfortunately enduring features of our state's workforce is the geographic maldistribution of workforce, that is to say, shortages of providers in rural versus urban areas of the state, and among urban areas, shortages that are more acute in southern Nevada than they are up north. The final feature of our state's workforce is what I call the diversity mismatch. And that is why we've made great strides in increasing the number of providers who are women and people of color. We have a long way to go before the provider population matches the communities they serve. I think about right now what's on a lot of people's mind, addressing vaccine hesitancy and uptake over the next couple of months. I think that would be improved if there were more people of color that those populations trust, if there were more Spanish-speaking primary care docs and pharmacists. Again, that diversity is important for a lot of things that we face as a state. I'll quickly go through some recent supply strains and shocks. We've mentioned the Affordable Care Act. I think demographic and ACA-induced demand on the whole has been a good thing, but that has produced some strains on our state's workforce that was already underdeveloped compared to other US states. Additional strains, if not shocks to the sector, include our current pandemic capacity and response. Presently, there's a nationwide bidding war for traveling nurses, particularly in critical care. And for the last couple of years, I felt like we've been on the cusp of a pretty severe nursing shortage in Nevada. I think with the pandemic, we are there. And looking beyond the current pandemic, post-pandemic world, a big concern of mine is that an aging nursing workforce exhausted by the demands of the pandemic will be quicker to leave the workforce as they approach retirement. Their economy improves, retirement portfolios improve, and so forth. Finally, I don't know if this is a good news, bad news story yet, but national data indicates that the health sector is already in that V-shaped recovery. That is to say, that shock and drop in demand for health services that we saw in April and May is improving or returning. I think that will be a very uneven recovery at best, and that primary care will recover quicker than, say, dental practice in some specialty areas. I think it'll take the better part of 2021 for that to shake out, but I am bullish that demand for health services in Nevada will return to pre-pandemic levels over the next year. I don't think I would make that prediction for any other sector of our state's economy now. More to be seen on that. Huge implications for the state's workforce. I now, in the next couple of slides, want to turn to provider shortages, starting with primary care workforce shortages. This and the next three slides highlight what are called HPSAs, or federally designated health professional shortage areas in Nevada. In the most general terms, HPSAs refer to areas of the state in which population to provider ratios are high or really severe. The darker the shade in the next set of maps, the worse the shortage area. This first map provides a visual snapshot, pretty current data here, of primary care shortages designated actually by the primary care office, working with the federal government on those designations. The blue shaded areas are shortage areas, with the darker blue areas representing areas in greatest need. Currently, by our estimate, 1.8 million Nevadans reside in a primary care shortage areas. That represents close to 60% of the population. At the county level, 10 of the state's 14 rural and frontier counties are single county primary care HPSAs. Those areas that are not currently designated as shortage areas, such as up around Elko, you lose one primary care doc and you can easily flip back into a shortage designation. My office also has some pretty detailed maps for Southern Nevada and northern urban parts of the state. I'm going to just share one of those with you to highlight that those designations go down to the census tract level. And if we look at what primary care shortages in Clark County look like, take a trip around the Beltway and you will go from very severe shortage areas in North and East Las Vegas, moderate ones in the southwestern part of Clark County, to areas that are not considered shortage areas in HPSA terms. Nonetheless, 1.4 million Clark County residents reside in a primary care HPSA. That's a little higher than the state average, but we're estimating that about 63% of the county's population resides in a primary care HPSA. Similar story with dental workforce shortages, not quite as severe as primary care, but nonetheless, roughly half the state resides in a dental workforce shortage designated area. Likewise, we have 12 single county HPSAs in Nevada, including, again, 10 of 14 rural and frontier counties, and both Washoe County and Carson City represent single county HPSAs in the dental. I've saved the worst for last, mental health workforce shortages. These maps have not changed a great deal. Close to 3 million Nevadans reside in a mental health care HPSA, rather. That translates to 95% of the state's population, including 100% of the residents of Clark County and Carson City. At present, there's 16 single county mental HPSAs in the state, including all 14 rural and frontier counties. I want to kind of close the discussion of provider shortages by sharing a little bit of data that we've pulled together on what it would take to move from those poor rankings of 49th or 50th that you've heard about forever to the middle of the pack. When I speak with lawmakers, I think they get a little bit of tired hearing that we're 45th or 46th in the number of physicians per capita, or 49th or 50th in registered nurses. I don't think the rankings give us much guidance in terms of what the scope and magnitude of our shortages. So what I've tried to do is examine some key professions focusing on the per capita rates in Nevada and a subset of the state in Clark County, and ask what would it take to move Nevada to that national average, so that our current average for physicians is 220 licensed physicians per capita. The national metric is 282. How many more docs would we need in the state of Nevada to meet that national average? Now, I want us to be more aspirational than being average, but again, for argument's sake, what would it take to move to the middle of the pack? And our data suggests that, among other things, we would need 2,000 plus physicians just to move to the middle of the pack. If Clark County were to move from 217 to 282, that county alone would need 1,500 additional physicians. More ominous, we need close to 9,000 RNs to move to the middle of the pack. Clark County would need 6,300. I promise I double check these numbers every time I update this slide. These are some pretty staggering numbers, but I think they speak to what it would take as a state simply to move to the middle of the pack. I now want to turn to some of those policy strategies that I alluded to at the beginning of the discussion and argue again that many of what the strategies and measures that I'm going to talk about have actually proven quite successful. I'm going to end with a couple of success stories to highlight. We know what we need to do as a state to address these shortages. Again, whether we have the leadership, ability, and dollars, particularly in the current budget crisis, to do that is another matter. The top of the list, kind of an implied priority on this slide, is we will need to expand higher education health programs and budgets. There is no substitute for medical programs, nursing programs, allied health programs that are the mainstay of producing our current and future health workforce. I think those same state agencies, at least on the public side, will be asked to take their cuts with the rest of the state. So I don't know what that holds for us, but I would be remiss if I didn't say that nonetheless is these shortages demand more, not less, health education programs. As was alluded to in Shelley Berkeley's comments, we also need to pay attention to residency and fellowship program development. We've got some good news stories to share in just a moment, but they include rural residency program development. We now have two programs, one in Winnemucca out of the UNLV Family Medicine Program and one in Elko from the UNR Family Medicine Program. But we need to do more work across not just residencies, but fellowship and subspecialty programs. I'm also going to highlight state and federal loan repayment in a moment. Would also highlight an example of where changes to licensing and healthcare professions compacts might hold promise for addressing these shortages, as well as changes to scope of practice and supervision requirements, not only for advanced practice clinicians, such as advanced practice nurses and PAs, but I think we also need to pay attention to the non-physician workforce, community paramedics, community health workers, and their role in shoring up some of our shortages. This commission will undertake and support a legislative bill draft to address and extend telemedicine capacity. I think that's important, but would only caution a lot of these measures presume that there is a physician or other provider at the other end of that telemedicine consultation. I want to close out the list with just a couple that I think are important because they address not only recruitment, but retention factors. And that is the ongoing need for us to promote healthcare careers, as I would say, as early as middle school and high school. And that if we're going to keep physicians and nurses, we need to continue to pay attention to provider reimbursement and work environment. So those success stories. I'm going to end on a high note and point out that the investments we've made in GME, while our GME programs are relatively small compared to most other states, including states in our region, what we've seen over the past decade is a steady growth in the number of physicians completing GME in Nevada. We only had 81 GME graduates in 2011. That has increased to close to 200 in 2020, an increase of 140%. We still have a lot of work to go. The slide I'm sharing with you now summarizes the results of an annual survey of GME graduates that my office conducts each year. Every spring, we ask graduates a very simple set of questions. First, are you beginning your clinical careers or practice? Or are you seeking additional fellowship training? And then second, I think it's the big question, Are you going to stay in Nevada to, again, either pursue clinical practice or continue training, or are you going to leave the state? And what this slide summarizes, this slide is not summarizing where the decades worth of graduates has eventually landed. It's where what they told us they were doing when they completed their residency and fellowship training, typically in June or July of each year. I'd like for you to focus on one cell of that diagram, and that's the 278 docs that told us they were leaving the state, and they were leaving the state to pursue additional fellowship training. The findings of our survey this year, which are contained in reports that you can find on the PPC website and agenda for today's meeting, as well as reports we have published in the past, strongly suggests that the development of fellowship programs in Nevada holds the potential for increasing the number of GME graduates who ultimately stay in Nevada to practice. If we could chip away at that 23.1% of overall graduates who leave the state, I think we can address some important physician workforce shortages. Success story number 2 highlights the importance of changes to licensure in the case of advanced practice nurses, who with legislation passed in 2013 were allowed to practice independently of physicians. The slide also underscores the importance of new health education programs, as is the case of physician assistants. The establishment of the PA program at Turo in the early 2000s, it mattered, as will the relatively new program up north at UNR Med. Both will only add to the number of homegrown PAs in Nevada. What's pretty cool about this slide is that not only have we seen in a very short period of time pretty spectacular growth in the number of licensed APRNs in Nevada as well as PAs, we have more than doubled the per capita number. Again, gains, it's difficult to imagine what primary care capacity, particularly in Southern Nevada, would look like without this spectacular growth in advanced practice clinicians. The final success story I'd like to mention has been the role that loan repayment has played in recruiting and keeping physicians and other practitioners in the state. Full disclosure, the Nevada Health Service Corps is overseen by my office, the Office of Statewide Initiatives. And for close to 30 years, we have supported 143 practitioners in every Nevada county. It's not just a rural county oriented program, but every county has benefited from this. The great news, and this is data just looking at the last 5 years, 70% of our supported health professionals have remained in Nevada once they've completed their service obligation and paid off their loans. Currently, we have 27 recipients that are practicing in 10 counties of the state, including urban counties of Washoe and Clark County. I would add that this, like GME funding, is something that in which general fund support has been critical. In 2019, Senator Hardy sponsored Senate Bill 289, which provided $500,000 in state match to a $500,000 grant that my office was able to secure from the feds. And with that funding combined, we have been able to offer $1 million in loan repayment support, again, for professionals practicing in every corner of the state. Give me more money. I'm confident we could replicate that going forward. What I'm really hoping that the legislature will have the wisdom to at least level fund that, because again, those physicians and practitioners receiving support by and large stay in the state. I want to conclude my comments by pointing out that a lot of what we've been talking about is the right number or amount of physicians, nurses, and other health workers to meet the needs and demands of the state, which will only grow. I'd like to also close by pointing out that Health workforce development is integral to any economic development and diversification strategy in the North. I mentioned Tesla up north and would just highlight that those businesses and individuals are only going to come to Nevada if they know that there are teachers in Nevada, there are pediatricians, there are other health and human services to support them in that move. The health sector in Nevada remains underdeveloped when we look at regional and national benchmarks, which is to say about 10 or 11% of our state employed in healthcare as compared to national averages of about 15 or 16. We have a lot of work to go there. I would finally add, it's a pitch I make anytime I talk about health careers to high school students or college students, and that is the health sector remains a source of well-paying recession. I used to say recession-proof jobs. I don't say that anymore, but they are certainly recession resistant. If you are an individual going in to nursing or mental health or medicine right now, I can guarantee you that you will have a good paying job 5 years from now, 10 years from now for the remainder of your career. An investment in our state's health workforce is also an investment, not just in our future health, but also part of what I think it means to have a diverse economy that attracts businesses and at the same time addresses the health needs of the state. With that, I'd be happy to answer any questions you folks have.
Thank you very much, John. That was an excellent, pretty comprehensive presentation. I really appreciate that. That'll stimulate some vigorous questions. I think in the interest of time, it's 10:25. Hopefully we can wrap up our questions by around 11 so that we can move on with keeping in time. So I'll make one comment. The problem I've seen over the decades in this state, and whenever I've served on any commission or task force related to health, I've emphasized that we put a lot of emphasis on making sure there is enough money, beg, borrow, steal for education, which is great. It is important. But an unhealthy community in this state, healthcare has to be also a priority. Healthcare has never been treated as a priority at the top of the agenda at the legislative level. Over the years, multiple task forces, commissions have addressed that. And the reimbursement issue is a big issue with Medicaid because it's not addressed as a priority that helps to keep the doctors. And the GME part is another huge issue. Anything one can do at the legislative level to collectively address the budgeting needs for good healthcare access. It comes under the Patient Protection Commission. The patients are not protected in their healthcare if they don't have access to care, whether it be primary care, specialty care, hospital care, other care in all areas that you have alluded to. So I hope our next agenda item is somehow urge the legislature to take it as a priority in the governor's office to take it as a priority like we do with education other areas. Having said that, I'll open up to questions, and I'm sure there'll be a lot of questions. So if we can keep our responses and questions focused and to the point, that will help us be on time. This is an important subject. So please proceed, Sarah.
Sure. Let's start Commissioner Bohannon.
Thank you. Thank you, Dr. Packham. That was a really helpful look at the shortage and the need in Nevada. I have two comments and I have a question. One comment about one of your last bullets about how a healthcare job can be recession-proof and a good paying job. I just want to comment that that isn't necessarily as true when you said there's a shortage of epidemiologists in public health. That is not necessarily the case in that sector. State pay has been frozen. They're usually some of the first people to be impacted. So that may be true for nurses and physicians. That's not necessarily the case, I think, for public health. I also want to make a comment about how, because you brought up Tesla, and one of the downsides of Tesla is how it has impacted more maybe in the north. I don't know that this is necessarily as true in Clark, but our housing is outrageous here in the north. The median home costs $460,000. Median rent is about $1,400. I often housed travel nurses, people doing all kinds of rotations, and housing was a huge issue for folks. So I'm curious how much that impacts people's decision to stay in the area. And I'm also curious, when you look at the numbers of how many physicians we need, where do PAs and NPs fit into that? Do they fall into that category, or do they fall into another category in terms of meeting our need? Thank you.
Yeah, I'll try to address what I can remember. The nurse practitioners and PAs really aren't factored into, for example, the primary care shortage designations. With that said, there is a lot of modeling right now on current and projected physician workforce needs that absolutely do that. And again, when you are adding the number of nurse practitioners that we are in our state, particularly in Southern Nevada. I mean, the legislation that drove that growth in nurse practitioners was kind of sold as a rural remedy, but where I've seen the most growth in nurse practitioners has been in Clark County. And again, don't want to go there with them doing the same as a family medicine doc or a PA doing the same thing as a primary care doc. We are making strides in addressing primary care capacity with those advanced practice clinicians. So I still think that that's a good story. The begin-end time from somebody graduating from college and completing their residency and fellowship training in primary care is a long time. I think that's been truncated with some of the advanced practice clinicians. There's always kind of good and bad with a company bringing 7,000 jobs to the area. I'm going to focus on the good side, but a lot of those individuals, as you noted, are coming from California, selling their $800,000 house and then buying 2 or 3 in Reno and making it really difficult for the rest of us to afford housing there. I think that's another kettle of fish, but I acknowledge that that's a problem in the state. As to, I think that you had mentioned something about recession. I actually used to say recession proof in my slides. I say recession resistant. So I've qualified that. I think though, I'm optimistic though, that not just public health departments, but large businesses such as casinos will begin to recognize the value of having an epidemiologist on their payroll. I think we'll be doing a lot of things differently, guardedly optimistic that will include greater roles for public health professionals.
Sorry, thank you very much. Next, Commissioner. I hope this time Dr. Barron is not again in the end of the list, Sarah.
Does Dr. Barron want to speak now? I have it. He is actually the last one on the list to speak. But Dr. Barron, if you'd like to speak, you can. I just know from before we were not hearing from the patients first before we were hearing from some of the doctors, which I think was more beneficial to the conversation. But Dr. Barron, certainly, if you would like to speak before the patient advocates, we can have you speak.
Well, geez, you're making me feel guilty with that preamble. I'll try. I'll speak and I'll be brief. Thank you for putting me second. I included in your packets today, and I think Sarah distributed to the group over the weekend, some additional information about GME and statistics about retention of GME graduates in our state, which I found very interesting. And this was brought forth by one of the faculty members at Toro University, who did this study with some medical students about 2 years ago, and actually updated the information for the poster that's added. And I think that the point that comes out of that is that there's no question that expanding GME and fellowship programs in the state will help to serve and increase the number of graduates staying in the state. There's no question about that. However, when you look at people who did medical school and residency in the state versus people who just came here for residency, we lose more than half of the people that just come here for residency, whereas we retain somewhere upwards of 75 to 80% of people who do both medical school and residency here. And the reason I bring that forward to the commission is that in any discussion about further advancing funding for GME, I think should come with some incentive criteria for the GME programs to selectively try and recruit Nevada medical school graduates to their GME programs, rather than just filling them with anybody from the match. If we're serious about trying to retain graduates here in Nevada and make it bring to fruition the idea that expanding medical school enrollment and so forth in our state is going to make a difference in our workforce population. So again, with the way I look at it as when there is funding to expand GME from the state, because I kind of suspect, like everybody else on this commission, that there isn't going to be discussion about advancing GME funding during this next legislative session because of budgetary constriction. But when we talk about future plans and recommendations to the governor, we may want to tie some incentive to GME funding from the state with trying to get Nevada medical school graduates into these programs. So that was just going to be my contribution to the discussion about GME. Dr. Packham, I always enjoy your presentations, and I think that there was a lot of really good information that was presented today. Thank you.
Thank you.
Thank you, Howard. Appreciate it.
If there was a question there, Howard, I'm going to remain agnostic on it. But where I've changed my thinking, though, in the last couple of years is the importance of the fellowship. Just losing almost a quarter of those graduates over the past decade for fellowship programs. Yes, it would be great if we could get more UNR Med and Toro grads into UNR and UNLV family medicine and internal medicine programs. But I would add part of the reason why they're leaving is because at least up north and what I'm more familiar with, those grads are competitive nationwide for other residency programs. So a little tip of the hat in that regard. But I'm really thinking that we will make progress as a state when we develop those fellowship programs, largely in Southern Nevada, where the population health needs warrant that kind of fellowship program development.
Thank you, John. Sarah, next commissioner online.
Sure, since we took some things out of order, it looks like Commissioner Bond has her hand raised. Can we allow her to speak, and then we'll go back into the rotation that we have?
All right.
Okay, Commissioner Bond.
Thanks. I just wanted to, I think today's interesting. I think it's really good to see all of the uninsured numbers next to the physician numbers. I think a problem that Nevada has, and I don't know if it's something this commission could try to creatively think how to address, is we don't try to align physician improvement numbers with public nonprofit care. And so you've got, as we grow our physician groups, which is important in some of these sectors, and I really appreciate the presentation. Thank you, Dr. Packham. We're not also prioritizing making sure that we've got enough federally qualified healthcare centers and enough providers in those federally qualified healthcare centers and enough places for people without any coverage to go, like we're doing these in different streams. So we may end up with a lot of doctors in one arena and not solve our problem that we just heard about with the uninsured. I know the hospitals have to take all comers in the emergency room, but patients that need specialty care have nobody if they don't have coverage. So I feel like we don't have these things aligned together, though they were presented in tandem in a way that I think is really helpful to see. So I appreciate that. I think the other thing about GME is I think I'm remembering now that we're talking about it, sort of the conflicts in the legislature about where GME dollars should go. And I think I would just make another plug again for capacity is great and we need as many GMEs as we can, I think, but I think that public funding should go towards public institutions and public support And I think that is going to be one of the things that we should be careful about as we decide as what we're going to hash out in the Patient Protection Commission. Because if you take it out of the public sector and take that money into the private sector, the public sector has no way to make more money.
I
thanks for
will really remain agnostic on that comment, but I would point out that our fight, if you want to call it a fight, will be simply just to retain that $10 million over the biennium. In a perfect world, we would double that amount. We need to be wide and deep on residency and fellowship programs, particularly in Southern Nevada.
And for the primary care sector,
Absolutely.
completely agree with that.
I mean, I think Governor Sandoval's wisdom was to say, make it primary care and behavioral health, or I think the applications would have been off and running for specialty and subspecialty fellowship programs, again, which we need, but prioritizing primary care and behavioral health was very important in the launch of the way those dollars were spent.
Yeah.
Thank you, appreciate it. Next commissioner in line, Sarah.
We're going to go back to the rotation and see Commissioner Roa Dugan. Oh.
Are you on mute?
So you're not on mute, but we can't hear any audio from you.
Can you hear me?
Yes.
Okay. Okay, thank you so much, Sarah, and thank you, Dr. Packham, for that presentation. So it aligns very much with what I'm feeling and living every day as a registered nurse working in the hospitals in Las Vegas. So I have a couple questions. So one is in the shortages in Clark County, we see that the main shortage is usually where the minorities live, and they're most likely to be the ones uninsured and were the ones that are going to be looking for care in the ER instead of getting care preventively, correct? So also with that, the medical and nursing shortage in Nevada. Can you hear me?
Yeah.
Yes.
Okay. It seems that there are some programs available for the doctors to stay in Nevada. Is there something that you know of for nurses to be retained, since we need so many and we have so many graduates every year that graduate nursing school? We have several programs, but is there something being done for the nurses to stay in Nevada and maybe create more workforce, especially in the areas that are underserved?
Yeah, so I did mention the Nevada Health Service Corps, and that is available to register nurse, actually all sorts of health professionals. There's also federal nurse scholarship and loan repayment programs, irrespective of what we have here in the state. But you are absolutely correct. I mean, it's the final insult to those in our society who already face insurance and affordability barriers in care, that they literally live in areas that are the most severe in terms of provider shortages. And I only shared the Clark County primary care map, but I assure you that the mental health and the dental health map just overlays on that. There's shortages in almost every provider category in North Las Vegas and east and around the strip.
Have you seen that? Why are there so many nurses not working in Nevada, since we have so many nurse graduates every year?
Well, I think it's that, and I've been looking at nursing issues for about 2 decades. Part of our problem is we started off at such a low level, okay? To date, by my count, I believe we have 6 or 7 public nursing programs. Compare that to any state that surround us that have dozens of nursing programs. We never developed an academic health sciences center in Las Vegas, like Arizona and New Mexico and Utah and other surrounding states did. So part of it is historical. We didn't make the investments 3 or 4 decades ago, and I think we've suffered as a result. And I would say nursing falls into that category. Now, to our state's credit, we've doubled nursing programs in a couple of years or a couple of times over the past 2 decades. And we've also actually done a good job of recruiting nurses into the state. Again, the legislation that passed in 2013 did more to advance advanced practice nurses to the state than those, the programs that we have here in Nevada. We now have those programs, and they're doing quite well, and also addressing supply issues. But I think it's that historical disadvantage, but again, we know what works, and there's just no substitute for expanding those health education programs and keeping student debt down. Student debt.
Can I ask? Yes, sorry.
No,
Sorry
go
to interrupt. Just a couple more questions. So you said that you recommended for policy that there would be try to make the nursing compact, make Nevada a compact state for nursing, and also for make it easier for doctors to practice in the state. Do you see more of a benefit of doing that, or is that going to be a risk for maybe nurses that live in Nevada, go to school in Nevada? Would they be at risk of losing an opportunity to stay and work in Nevada if other nurses come from out of state that are maybe paid less?
Yes, I say reciprocity and compacts cut both ways. And that's why I think any type of policy recommendations I make, I think we have to be attentive to things like pay and benefits, job conditions, and so forth in hospitals and other healthcare settings. If we're not doing that in tandem with reciprocity, nurses are smart people. They will go where pay and working conditions are better. We can't allow that to happen.
And lastly, since this is a patient protection commission, and you mentioned nursing is a very good paying job, just like, I don't know about medical school. I can talk about my experience, but it seems like it's less and less well-paying and more sacrifice. But if we want to increase the workforce, it would be a good idea to use nursing as an encouragement for those people in the state that don't have jobs. What would you recommend to encourage the population in Nevada to go into a career in healthcare, nursing, or like medical school? What type of programs are there for the population to encourage them to go into that?
That's another lecture, but I'll keep it really short and just say your community colleges are already working on that. There are career ladders in non-nursing fields and nursing that get their best start in the community colleges. We've got the RN to BSN programs now in both north, south, and rural Nevada with the program in Elko. So the career ladders are actually pretty strong in nursing. And I think that might be a place to start.
Thank you so much.
And I wanted to just say, I think I speak for a lot of people. I appreciate your work in healthcare. I've witnessed the pandemic from the sidelines and the comfort of my couch, and you folks that are stepping inside a hospital every day have my admiration and thanks.
Thank you.
Great. Looks like we have Commissioner Bond. Did you have one thing quick?
Yeah, I just wanted to say one more thing, and I have to leave early, which I apologize for. I think this whole discussion we need to figure out interim strategies. And while we figured out that this commission is going to support the idea of payment equity for telehealth, we haven't really thought about how to fix the legislation to allow out-of-state telehealth to happen where it needs to happen, where we have these shortages. And I think this conversation is raising that issue as something that maybe the legislature can take a look at the current telehealth laws about restrictions to state licensing when there's so many out-of-state groups that could help us in shortage areas. Thanks.
Thanks, Commissioner. Looks like Shaner.
Thank you. Appreciate it, Dr. Packham. Thank you for the presentation. It's humbling to see the actual numbers of the shortage with respect to how many more providers or nurses we may need for the state. It puts it in some perspective. And I apologize if you shared it with us and I missed it, but from a pay perspective of providers on a net basis, not a gross basis, but when you factor in the various tax structures across the other states, how do we in Nevada compare to our competitors, our peers, from a pay perspective of providers? Obviously, providers coming out of training look to get as much as possible to pay down the debt. But I'm just curious as to how we compare to our peers and are other states paying better?
I should know the answer to that question, Sean, but I don't. But it's at the risk of stating the obvious, it's an important part. I am amazed, and I don't know if it's pay or if it's the lack of a state income tax or housing in Nevada being cheaper compared to California, but we still do a pretty remarkable job of recruiting licensees from other states. I get a stack every quarter from the Board of Medical Examiner on new licensees to the state. And I'm just still stunned and impressed by the numbers that continue to come here.
All right. Thank you very much. I appreciate it.
Thank you. Who do we have next?
Sorry, I have to apologize. Going out of rotation confused me. So Commissioner Flood, I didn't mean to pass over you. You're next, and then it'll be Commissioner Flocon.
Great, thank you. I was actually going to start off my comments with what Chair Bond was saying, or Commissioner Bond was saying, and that's kind of what Chair Khan, I think, was alluding to as well. This is a great opportunity, I think, for us to identify some real recommendations to advocate in workforce development, if anything, just to like stop money from flowing out of the current efforts that are occurring. So I just wanted to say that. I really appreciated your highlight on increasing diversity. And I was wondering if you know what the education systems are doing to try to increase diversity in our healthcare workforce.
I honestly don't know that in much detail. I would say that it starts with recruiting women and people of color in the first place. And so
right.
I'm more familiar with programs up north, but I think that's where you start. But
yeah, and no problem. You know, it's something that is like this very peripheral conversation in a lot of meetings where it's like, oh, and we also need to think about increasing diversity. And that I think could be another opportunity for this commission recommendations is how do we like really make that kind of a central drive for many different working parts of our, government and organizations, like almost a primary piece of when we start to form commissions, making sure that, diversity is reflected in those leadership boards, commissions, et cetera. I've just been thinking about that a lot in my current work. And then I also really appreciate the highlight on the mental health workforce shortage. It's obviously severe. And so I was wondering if maybe as a commission, eventually we could look at even innovations that Nevada could look at nationally in utilizing our current workforce to access mental health services. So I've heard a lot about primary care and behavioral health care integration models. I just heard about one where psychiatrists can kind of do case management and oversee the care in tandem with primary care physicians so that primary care physicians can take on more complex mental health cases. I know Washoe County just contracted with Talkspace to provide some access to mental health, whatever that looks like. I know that was kind of controversial, but still kind of an attempt to expand access. And then also 988, I just want to put on the commission's board. That'll be like our nation's 911 for mental health. So instead of people calling 911 for mental health crisis, we would hopefully divert them over to 988 to utilize our crisis call centers. So I think that mental health can be intimidating and it's easy to kind of gloss over that. But I just hope that the commission might consider doing a deeper dive on some of the innovations that we could look at.
I agree. And boy, Talkspace, I think, is interesting. It's been in the newspapers, of course, up north. Mayors and city councils typically stay out of healthcare and those kind of measures and leave those up to the counties and the state. But I think it speaks to the desperation that policymakers at the local level in the state are facing in addressing mental health needs, that we would even engage, a firm like that with text therapy, I think is the model. I think the jury's out on the efficacy of that, but I'm sympathetic to the desperation almost. I hate to put it in those terms, but I think that's what we're facing. I would add and have the commission consider a future presentation from Sarah Hunt at UNLV School of Medicine. She's got a great, what do you call it, ready-made behavioral health pipeline model that she's been analyzing and developing based on what's worked in Nebraska in getting individuals into behavioral health careers in particular. And so, again, there are models out there that work, and we could benefit by, at least, I agree, discussing those.
Thank you.
Great. So we have Commissioner Flocon next.
Thank you, Sarah. And I just wanted to say first and foremost, thank you, Dr. Packham, for the presentation and the materials that were sent earlier. They were very informative. And I agree with many of the commissioner's statements today, starting with Commissioner Barron's initial communication regarding retention of the existing either residents or students in the healthcare space, because we do see, we see it here in California too, where we educate them and then we educate folks from outside of the state and then they leave and then they don't stay. Whereas if we allowed for more people from within the state to stay or to actually have access to a lot of those programs, they would actually stay in their home state. And for many reasons, it could be housing costs, it could be the payment schedules, whatever. And so I do think that's an issue. I also agree, though, with Dr. Packham that you want the diversity coming in from other areas as well, but a majority of those folks should be allocated to those that actually reside in Nevada. I would also agree that with Dr. Packham's statement about we need to start earlier than just, the medical residency programs and whatnot. We need to start in the high school and educate and really to the diversity issue that Commissioner Flood mentioned, we've got to start capturing those folks early in the education system and in the education process. And that's been one of our goals at PhRMA, is to really promote STEM education at an early age. And we've been trying, although small amounts, but trying to give some funding, particularly into those underserved communities and communities of color, so that we can attract more people into the sciences. And that is something that I know we will continue to do, but it's important that that investment be made. And with that, I'll just close. I think it was really helpful to see the numbers. I think there's, like you, I want to think of it, there's both short-term goals that we can accomplish, and so the licensing and credentialing, if we can do something quickly on that, but then the long-term really is the investment in the education system. So thank you for that. Thank you for the presentation.
I agree, and I just will share one anecdote because I think it's important. I've been very encouraged during the course of this pandemic, which is to say the last year, to be impressed by the number of individuals applying to both medical and nursing schools and programs across the state. There are over 1,500 applicants for the 24 PA spots up north at UNR Med. So at a time in which we're worried about our current and future health workforce, I think the pandemic, it's anecdotal, but I think the pandemic has actually generated a lot of interest in healthcare careers, which I take some comfort in.
So thank you, John. Just on that comment, you have 1,500 PA applicants in North, and I think in the South, I don't know the exact number, but they have a pretty large number of PAs they are graduating here. from Toro also, besides the medical students, 180. So I think they have a significant contribution to the workforce in the community. So I think that's helpful to know. The more the merrier. So
yeah, I agree. And Dr. Khan, Shelley Berkeley will have the exact numbers, but I believe last week she told me there's upwards of 3,700 individuals that have applied for those 160 or 180 DO spots. So there's a lot of interest here in Nevada, which is good.
So that's helpful. We'll have public comment, and we don't know whether she'll come back, but she may be coming back for the public comments. We'll get some of these answers on it. So we can move to our next commissioner on the line.
Sure. So I have Commissioner Sloan, but if you don't mind, Commissioner Barron said he just wanted to take a quick moment to make a comment, if that's okay with you, Dr. Sloan.
Sure.
Yeah, thank you. I just wanted to mention two things. One is with regard to diversity efforts at UNLV School of Medicine, there is a very concerted effort in the admissions process to diversify the admitting classes, and that has actually sort of been borne true in the first 4 years of students that are populating the UNLV School of Medicine right now. There's actually more women than men in the current the entering class this past summer, and there's a very almost disproportionate you can say minority population in the last few years of UNLV Med, and that's something that really kind of came as a directive from the top. So just wanted people to know that. And then with regard to I'm going to lose my mind. I wanted people also to know that with regard to getting into the high schools and so forth, the Clark County Medical Society has been running a mini internship program for high school students interested in health careers, in which they shadow a member of the medical society for a day every fall, basically, and that's led to a really nice relationship with the school district and with getting people interested in health sciences careers. So just wanted you to know that Organized Medicine has been working on that for several years, and it's been a really successful program.
Thank you very much. And by the way, I just have a message from Shelley Berkeley. She would be back on the public comment. So let's go ahead to the next commissioner, please.
All right, we've got Commissioner Sloan.
Thank you. Just a couple of comments. John, thank you so much for your presentation. First, comments in the context of nursing. With Commissioner Roe-Dugan, I'm also a nurse from the past, very proud graduate of a diploma school of nursing, actually. And I think that is one of the challenges that we've got is as we've pushed education in a number of disciplines, including nursing, physical therapy. Now, we're pushing towards more and more education, graduate degrees, where it may not actually, what we've learned, if anything, through COVID is the fact that we need bedside nurses. And so maybe we need to reorganize the way we go about delivering the care. We've moved from a frame of, highly educated, wonderful approaches where you need the critical thinking skills. And we've made bedside nursing very task-based. And so there's this disconnect that we have to overcome, I think, as we move forward. The second comment on nursing is while we do have, and I heard you on this, John, I think it's important to note, while we do have a lot of the community colleges stepping up, the four-year colleges in the state, the public universities, have veto power when there are opportunities, when one of the community colleges perceives that, one of the four-year colleges perceive that there's a competition between what a community college wants to put in place, example here, a nursing program, that's already present at a four-year university. And so there's this real tension point where we need more, but we can't get it because the four-year universities are standing in the way. I think that structurally has to be addressed. As I move comments over to physicians, let's make no mistake that we are certainly, the GME cap is important. And I'll end on the fact that, well, I think there's some things we could do around innovation here. Test cases on example, instead of doing 4 years of medical school undergraduate and then 3 years of residency, Let's figure out a 6-year program that saves a year and allows people to make a commitment to the community in Nevada, to the point that we have, public universities that are serving, that take a large percentage, 90% of Nevada grads, yet we let 25% of them leave the state is craziness. We've got to make sure that if we're going to protect our public universities for Nevada students, they stay. Not that 1/4 of them leaves and never comes back, because maybe we should take some out-of-state students and bring them in as a part of driving that conversation differently. So I think this area, to your point, what we've been doing isn't working. We have to be ripe for innovation and creativity if we're going to be successful.
Yeah.
Thank you.
And I would just add, we have kind of a, I don't know if it's a prototype, but something along those lines with the BS to MD program up north. And that's not truncating it at the spot you were talking about, but I think it's a recognition that by your senior year, if you are excelling in basic sciences, you can begin to move towards your MD degree in your senior year. So I think there's a lot of interest in truncating what is taking 12 years to go from a freshman to a practicing physician.
Thank you, Tony. Appreciate it. Do we have next in line?
We actually have, I think Commissioner Bohannon has her hand raised, but if she doesn't mind, one moment, I'm going to call on Commissioner Barron. I believe he has a tale to tell about out-of-state practitioners.
Yeah, I mean, it's just really, I was hearing what Commissioner Bond had mentioned earlier about encouraging out-of-state practitioners to practice telehealth within the state. And on the surface, that sounds like a really good idea, but the reason statute currently in Nevada requires licensure within the state in order for out-of-state people to practice here is that if, heaven forbid, there's a problem with an out-of-state practitioner, if they are not licensed in the state of Nevada, there is no recourse for the state of Nevada to discipline them. And so irrespective of whether you think it's a turf protection thing or not, it really has more to do with patient protection, that is in statute. And I would strongly encourage this commission not to try and loosen those reins, because there are opportunities for people from out of state to practice telehealth. We have telehealth that's going on from overseas with overnight radiology readings and things like that from Zurich, Switzerland, and from Australia and places like that. There's a precedent for all of those kinds of things, but they all require licensure and credentialing in the state, and for good reason. So I just wanted the commission to be aware that there is a pathway for that to occur, but because of the regulations and the need to be able to discipline errant physicians, we have to insist that they stay licensed and credentialed in our state.
Thank you, Howard. Let's go to our next commissioner.
Commissioner Bohannon.
Thank you. I have 2 quick questions. Back to Dr. Packham, your charts on the shortages. I'm curious where travel nurses fit into our shortages. Are they included anywhere in those numbers? Because I know we were quite a bit on travel nurses, so I'm just curious about that. And then I'm also curious, kind of somewhat in terms of the shortage and diversity, where do immigrants fit into this? How many people do we allow to come in on work visas to fill some of these gaps? And I'm just curious, a million years ago, I scored applications for residency programs for the School of Medicine, and I know there was just so many from out of the country. So I'm just curious if that can be something that our state can look to.
Yeah, I don't have data on traveling nurses, and it's probably been complicated by just trying to respond to the pandemic. I'm sure those numbers have even changed. I would maybe reach out to Dr. Sloanham or anybody in a hospital setting where they are being heavily utilized right now. In terms of international medical graduates in medicine, Nevada actually has one of the highest percentages in the country. I think we're in the top 4 or 5, and as much as 30 to 35% of the physicians licensed and practicing in Nevada receive their undergraduate medical education in another country. So it's actually pretty high. We rely heavily on foreign trained physicians.
Thank you. Appreciate that. Who's our next commissioner?
That concludes all commissioners' comments.
Okay, appreciate that. That was a very productive discussion, I think. So we have done well on that.
Dr. Khan, I wanted to just mention real quick, there's been a lot of discussion about high school students and healthcare careers and so forth. On the second slide in my presentation is a link to our healthcare careers manual. It's online. Anybody on the commission or anybody listening in today, I've got a pallet full of hard copies of that report that I would be happy to send to you. They are written to a junior or senior in high school, and they outline 70 healthcare careers in Nevada, where you go to get training, how much you'll get paid, and so forth. So I would love to share that document with anyone and everyone.
Thank you. So I would like to summarize my perspective on this. I think the biggest challenge in workforce, at least in the physician side, we've discussed the other areas also, is the availability of the physicians going to medical school here, staying in Nevada for their residency training, which is a huge challenge. Not all of them want to stay here. And if they go out for fellowship, like John, you alluded to, then the chances of them coming back are even much less. So all the more reason, in my opinion, that we encourage and do whatever we can in the GME sector. Once the medical school has the students, if they can be here for their residencies with the support in the GME side, as much as we potentially can get in the budget side, that would encourage more of them to stay in town. No guarantees, but I know I sat on the advisory committee chair for the UNLV Community Advisory Committee, and this has been a challenge. The UNLV has done a pretty decent job of first priority to admit Nevada graduates into the medical school or people with Nevada links. That is their first priority, which is very helpful. But then even if they get through the medical school, being from Nevada, if they're going out for fellowships, for some reason or the other, wherever they're doing their fellowships, those institutions try to keep them there, and sometimes they want to stay there. So that is also a challenge, whether it's UNLV or whether it's Toro. I think GME makes a huge difference. So having said that, we can just move on to our next item on the agenda, which is discussion of report to the governor and the director of the Legislative Council Bureau. Sarah, that's for you.
Yes, thank you, Chair Khan. Commissioners, again, this is just really an opportunity to open the discussion about our statutory obligation to submit another report. We have to do this each or every 6 months at a minimum, discussing our commission activities and any recommendations. In my last email to you, I gave a kind of a bullet list of some of the recommendations and activities I intend to include on this upcoming report. At a minimum, it'll include a summary of our meetings, the discussion and the recommendations that produce the legislative bill draft requests, and also the support of the Peterson Millbank program. In addition to that, the PPC indication worksheet and your recent ranked priorities that you have identified for this commission to take on for the foreseeable future. So this agenda item really is to continue that discussion, open it up, hear from you all. And so I will turn it back over to you, Chair Khan, to continue this discussion.
So do we have a draft, Sarah, on this for the report?
There's not a draft of the report. Rather, I think by default, what I'm going to do is follow the same format that I used or from my July 1 report that I sent to our governor. And so I sent that over to the commission as well as an example. So there isn't a draft. Right now, I'm just seeking input from the commission members, and you guys have the opportunity to discuss it now, or if it's more convenient for you, connect with me outside of the meeting and let me know if you have any input or thoughts or suggestions.
So I think probably in the interest of the time, I would really urge the commissioners to please chime in as much as you can possibly ASAP to Sarah. What's the deadline for the report?
I have to submit it no later than January 1. Given the holiday schedule, I'd like to submit it before, I would say the 25th, but I'm flexible. The pandemic, I think, has halted travel for many of us, and that is including myself. And so I'm flexible if there is any input that is expected or you guys want additional time. I'm mindful of having your input, so I can wait until that time. I just would like to have it ready to go by the 25th. Just
So,
add an caution.
that sounds right. But what I would really suggest, because I think all of us are very busy in multiple things that we are doing, but if we can chime in as much as we possibly can, whether in writing, whether on a telephone call with Sarah, to suggest your thoughts that should be incorporated in the report. This report is a standardized report that goes, like Sarah mentioned earlier, so it has a certain format, generally speaking, that it has to be followed. So I would appreciate each commissioner's input. I think 25th is already Christmas and 24th is Christmas Eve. So I think it probably we have another week or so by the 23rd of December.
23rd sounds better. Yeah, that's more realistic, and
Right.
my
If
little
we
one will
can
appreciate
chime in
that.
as much as we can, and so that, because what will happen is if each one of us promptly submits it, she can incorporate whatever suggestions are important in those areas and summarize it and hopefully send it to the commissioners before the 23rd of December, that this is the summary of everybody's input and this is what the final draft looks like, so that then everybody can sign off on that final draft and she can send it over right after Christmas before the new year.
Sure, and I really want to manage expectations on this because you just mentioned sign off on the report, and unless this commission decides to meet again, there won't be any formal action taken on this report. I think ideally, I would like to have formal action because this is your report as much as it is mine. And so if that is something that we'd like to do, we would have to make sure that this commission considers reconvening before this report is submitted. If you wanted to take some sort of formal action, it's not necessary, but I'm statutorily obligated to submit a report. So at a minimum, it's going to be following what I shared with the commission, but you know,
so
I'm open to suggestions because there isn't any actual standardized format or process. We're a new commission. These are new requirements, and so I just have a certain minimum threshold that I need to adhere to.
So, and that's fine. I appreciate that. So when I said sign off, I meant that everybody's suggestions have more or less been incorporated in that without us having to meet again, because it's impossible to meet again. There's not something
Sure.
sort of an emergency situation in getting our thoughts in. So I see a hand from Commissioner Flood.
Thank you. I in reviewing our past activities for the last quarter, I think we were really focused on the legislation. So it makes sense that maybe we don't have any identified recommendations right now that we found consensus on. But I just hope moving forward in the next report, like what we talked about today, I think if we could, like with Medicaid, workforce development, obviously I'm biased towards mental health, but really have very concrete recommendations to deliver to the governor. As a commissioner, that's what I'd like to see, because I see that you're going to report on our activity, and it's probably all that we can pretty much do right now without any kind of consensus or discussion. But moving forward, I hope that we can do that.
Appreciate that. Thank you very much. All right. So I think in summary, there's one
I think
particular.
Commissioner Barron has a comment.
Yes.
Yeah, I mean, I hear what you're saying, Sarah. And you know, you'd like to get the comments in as quickly as possible. I think there's some benefit to being able to share comments with the group as we see it. My comments are, you know, when I looked at the template from the July report, for example, it doesn't mention anything about our two BDRs, and so obviously you're going to incorporate some language in about what we submitted and what came back. And then it says also as part of that report from July, you know, no issues identified. And I think there's, as Commissioner Flood just said, I think we've identified a lot of issues. We haven't really developed consensus necessarily on in going forward on them. But you know, we know that there's for example, workforce shortage. We know that there's funding issues with regard to Medicaid. We know that there's you know, issues with scope of practice. We know that there's issues with rural versus urban coverage. We know that there's a funding shortage, all of those kinds of things. And so, you know, I think we could make an easy list of those things and just say we've identified these as problems and issues that the commission would like to go forward and work on and build consensus in the coming months and recommendations to the governor thereafter and for interim.
Yeah, I really appreciate that. And that's why when I mentioned, I think we're on the same page, the PPC's indication worksheet, and my reference to that was really to identify some of those high topic areas that the commission has identified as a priority, and then really kind of further showing that what came out of that was those 4 identified topic areas and a desire to take a deeper dive into those. I want to be very careful about the way this report or about what I report and reflect whether there was a general consensus or if it was just shared topics. And so if you want to send me some additional thoughts on sub items or subtopics that you want to make sure is included, I'm happy to do that. I'm happy to consider that. I will just make sure that the report reflects that those are personally coming from a commissioner and not speaking on behalf of the commission as a whole. And so really for me, I just want to be careful in that. And anyone who wants to share, by all means, I will then with you share with the entire commission so everyone is aware of who said what, but I will identify that it was not a consensus or agreement by the whole commission unless that does happen. And at this stage, that has not happened outside of the request for the 2 legislative measures.
I also just want to say, moving forward, I think that we tackled super controversial topics in the beginning, so it's hard to have. It's no wonder it was hard to find consensus. I think some of the other topics that we've talked about are far less controversial. And at least when we have these discussions, I hear more consensus and support for them. So just moving forward, I hope we could take a look at that.
Yeah, I really appreciate it. And I think what we've tried to do, and I'm working with Chair Khan, is allowing for you all to have an opportunity to discuss like future meeting agendas and future presentations. That's really meant as a platform to host a conversation for everybody so you can build an agenda. And I know I've spoken to Dr. Barron before too about really building a set of agendas or a set of meetings. So that way we can kind of manage expectations of everybody's input, schedules, and really what's going to be happening in the future, as opposed to doing it in between each meeting. There's a lot of work that goes into planning every meeting, and being able to build that out over several months, I think is really beneficial, not only for each commissioner's time, but also for the public watching so that they're aware of kind of what's in the pipeline. I think right now, the only thing that we can really show is those identified 4 priority topics, knowing that each meeting will be some sort of a discussion around one of those 4 topics.
All right, that makes sense to me. So
it looks like I've got Commissioner Bohannon.
Yeah, just really quick. I am curious. I know we have our public website, but is it possible to host a private site for the commissioners so that a lot of this stuff can be categorized agendas, meeting materials, this report, because I feel like I somehow missed that you sent out the July report. I didn't even know that existed, and I'm looking back through my emails and I'm trying to find it. So I'm just curious if there's a way that we can better organize the types of products that we are going to start to generate as our work really starts to gear up.
I think you're talking about like maybe like a shared drive amongst everybody. Is that what you're, where it kind of
Yeah, I mean, as somebody
all of
who
that information?
Yeah, as somebody who develops technical reports on a daily basis, I mean, a shared drive would be amazing. I don't know if that's really feasible, but something that where there could be a place where it's just a little bit better organized, so that we're not searching through emails or whatever. But yeah, if it's possible where it's private and obviously not accessible to the public until it's a public.
If you shut off your video, you might get a better audio. Your voice was cutting off.
Oh, it was clear for me. But Commissioner Bohannon, I think that's a great suggestion, and I'm definitely open to exploring that. I would defer to our attorney on the line who likes to remind me that we must be compliant with open meeting laws in our state. And so I'm not sure we can have a private website or portal, but I'm certainly happy to look into finding a way to kind of better organize all of our materials, because I agree with you, it is a lot. It's a lot for me to manage personally. So I understand.
So Sarah, could we take this offline and discuss directly with the commissioner what can be done, and let the other
Happy to take it
commissioners
offline.
know?
I'll commit to working with Attorney Ott. Yes, Attorney. Okay, great. Thanks so much.
Okay, perfect. All right. So I think we really need to move on to our next item of, let's see, where are we? Public comment coming in.
I think we have one more agenda item. That's just your
that's
standing
right.
agenda
That's,
item.
discussion, potential agenda items for future meetings. Go ahead, Howard.
Yeah, I was just gonna piggyback on what Sarah was just intimating earlier, which is that if the commission going forward for 2021, or at least maybe the first 6 months of 2021, could come up with a monthly meeting schedule that we could calendar, that would be super helpful. And if we don't need to meet, in a certain month, it's easier to cancel than it is to all of a sudden like clear your calendar for a morning. I hope I speak with not just for myself, but for others, that's an easier way to go about it.
Howard, that's a great idea. Coming January, Sarah, we can send out the general listing for potential meeting dates and then go from there and chalk them out for at least next 3 months. Is that okay, Howard?
Yeah, I mean, if we could just, if we could just agree that whatever it is, I mean, we've been meeting on Monday mornings, so if whatever it is, the second Monday of the month or the first Monday of the month or the fourth Monday of the month, if we can just go forward and say, okay, we're just going to calendar those, through March or through April or whatever people's flavor is, that would be super helpful.
So that makes sense. So let's look into that, Sarah, and then share with everybody if the second Monday is, if that's what we think is the best.
Yeah, sure. I will.
Second or third, whatever it is, by consensus, that's what I mean.
Okay, great. Now I'll have to look at it. And I think what I want to do is I want to be mindful of the legislative schedule for the next 6 months
Yes.
too. So let me look and see what date it is. I think it would be for me, commissioners, I want to be mindful of when the healthcare committees are meeting. And so I do not want to schedule a meeting at the same time that those committees
No,
are.
which is fair and understandable. If we can just offline look at those options and where your committees are, but they may not be possible. So it won't happen today. You'll have to work through the logistics of it, then dates and options, and share with all the commissioners. So we'll take that on. I think we need to move on to our next item. Let's see. So that was item 8. So number 9, we back to public comments. Do we have anybody signed up over there? I believe Shelley had mentioned earlier to me that she would like to speak in the public comment. Is there anybody else?
Let's notify the public. So anyone who is participating online or who's dialed in via phone, if you're on phone, please press *9 to raise your hand. And if you are joining us via attendee on Zoom, you can go ahead and virtually raise your hand. It looks like we do have the Honorable Shelley Berkeley. I am admitting her into the meeting now.
All right, go ahead. Is she on video Zoom or audio only?
It looks like she is on audio only, but that's by
Okay.
choice. That's by choice.
Fine. Okay.
And so she should be able to speak now.
I am ready. And I
Great.
know I'll be very quick because you're running long. I almost fell off my stool when I heard Babette's suggestion that GME is only for students that are going to Nevada State schools. I worked with Governor Sandoval to make sure initially that this was not, oh, there I am. This was not a part of the GME proposal. And I'll tell you why. We're in desperate need of healthcare providers, particularly doctors in this state. And to take away the potential of 180 students that graduate Touro each and every year, many of them with our Nevada residents, to prohibit them because they're going to a private nonprofit institution would be insanity on our part. Dr. Peckham was quite correct. We have 3,700 applications for 180 slots. We can afford to be extraordinarily selective of who we allow into our program. We have 100% match every year. We are #1 in the country when it comes to the COMLEX test after the first year, and a 98% passage between the second and third year. You do not get better than that. We are attracting the best and the brightest, and so many of them have an attachment to the state, and so many others will end up practicing here because they can get a job immediately after their residency. So I urge you not to go down the path of being restrictive when the state of Nevada is so desperate for healthcare providers. It doesn't make any sense for an institution like Touro that is graduating 180 future doctors every year to make them leave the state when they could be very much a part of the solution, and they want to stay here. They want to start their practices here. They want to practice here and have get married, raise children, and have a life here. Do not prohibit them from doing this. It would be folly on our part. So as I said, Governor Sandoval and I worked very hard to make sure that that was not a part of the original GME legislation. And I would hope in our collective wisdom, we would not be restrictive. Touro is a gift to the state of Nevada. Don't take any state money, but we are every year producing 180 future doctors. And remember the national statistic, 70% of doctors end up practicing where they do their residency. We can be assured that if Touro students are accepted in residency programs, as they are now, that 70% of them are going to stay. I mean, how fantastic is that? And particularly given the fact that a majority of the Touro graduates go into primary care. What is our greatest shortage in the state of Nevada? Primary care physicians. What is Touro graduating? Primary care physicians. So I just wanted to bring that point of view to you so that you know how important it is that the GME program should be available to every graduate of a Nevada a medical school. And with that, again, Dr. Khan, if anyone has any questions, I'll be glad to answer them, but I know you're very short on time, and I thank you for giving me the opportunity to share this with you.
Thank you, Shelley, appreciate that. Back to our agenda items. Unless somebody had some pressing question, we can move on to the next agenda. Commissioners, back to the commissioners. Anyone? All right. If none,
It looks
I
like
think-
Commissioner Bohannon wants to make a comment.
okay.
Yeah, this is very, very quick. I just want to commend Dr. Slonim for doing some amazing work in our community. An amazing field hospital, and I've seen him quite a bit in the news lately. And I just want to say thank you so much for doing the amazing work that you have at Renown, and you know, putting beds in a parking garage. I know was no easy feat, and those patients are getting care where they otherwise may not have been. So I just wanted to say thank you so much, and that was it.
Thank you. So before we adjourn, anybody has a pressing comment or question? You see any, Sarah?
I don't, but if I can also take a quick moment, I really want to extend my gratitude to each and every one of you for your willingness to be a part of this commission and your continued engagement. This year has had many challenges for each of us, and we're new, we're adapting. I didn't expect after our first meeting that we would be meeting virtually, or I'd become such a tech savvy person when it came to Zoom. And I appreciate each of you, your patience, and your continued participation. So I'm not sure if we'll have a chance to speak again in this setting for the rest of the year. So I wish you all happy holidays and a great new year, and looking forward to better times in 2021. And Dr. Slonim, I echo the comments of Commissioner Bohannon. Thank you so much for what you're doing for the state of Nevada and for patients.
Thank you all.
All right. Happy holidays to everybody. We'll see you all next year. And thank you very much for all your effort this year. Appreciate it. Take
Thank you.
care now.
Bye.
Bye.
Bye, thank you.